A 67-year-old male presents with mild, atypical chest discomfort. I am showing you his frontal chest radiograph and an axial contrast enhanced chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates a well-defined mass in the middle mediastinum, projecting along the lateral aspect of the descending thoracic aorta. The border of the mass is contiguous and indistinguishable from the aortic contour. The contrast-enhanced chest computed tomography scan confirms a focal, eccentric outpouching arising from the anteromedial aspect of the descending thoracic aorta just distal to the aortic arch, at the level of the aortic isthmus, showing peripheral calcification and eccentric mural thrombus.
State your primary diagnosis and how you would classify this vascular lesion by shape.
The primary diagnosis is a thoracic aortic aneurysm. Classified by shape, this is a saccular aneurysm characterized by a focal outpouching of a portion of the aortic wall.
If I tell you the patient survived a severe deceleration motor vehicle accident 20 years ago, how does that guide your understanding of the etiology?
With that history of rapid deceleration trauma, this is highly consistent with a chronic post-traumatic pseudoaneurysm. The location at the aortic isthmus is classic due to tethering by the ligamentum arteriosum.
Explain the classification of thoracic aortic aneurysms based on the integrity of the aortic wall.
Aneurysms are classified as true or false. A true aneurysm involves dilation of all three intact layers of the aortic wall. A false aneurysm, or pseudoaneurysm, is caused by a disruption of the intima and media, with the extravascular hematoma contained by the adventitia or surrounding perivascular connective tissue.
What are the common etiologies associated with true versus false aneurysms?
True aneurysms are most commonly due to atherosclerosis or genetic disorders causing cystic medial necrosis. False aneurysms are typically traumatic or infectious, also known as mycotic pseudoaneurysms.
How does the shape of an aneurysm, specifically saccular versus fusiform, affect its rupture risk and clinical management?
Saccular aneurysms carry a significantly higher risk of rupture than fusiform aneurysms of a similar size due to concentrated, unequal wall stress. Consequently, saccular aneurysms are managed more aggressively and often warrant earlier intervention.
What are the classic radiographic and computed tomography signs of an impending aortic rupture?
Key computed tomography signs of impending rupture include the draped aorta sign, where the posterior wall conforms to the vertebral column, the high attenuation crescent sign within mural thrombus, indicating acute hemorrhage, and focal wall disruption or peri-aortic hematoma.
State the normal pulmonary venous wedge pressure and explain how vascular abnormalities present as middle mediastinal masses.
Normally, pulmonary wedge pressure is under 12 millimeters. Vascular anomalies or aneurysms are a major cause of middle mediastinal masses, as they lie in the middle mediastinal compartment alongside the great vessels, heart, and trachea.
What is the preferred intervention for a descending thoracic aortic aneurysm, and what is the size threshold?
The treatment of choice is thoracic endovascular aortic repair, or TEVAR, which is less invasive than open graft replacement. The intervention threshold for descending thoracic aneurysms is 6 centimeters, or earlier if it is saccular, symptomatic, or rapidly expanding.
Detail the immediate medical management required for a patient presenting with an acute, symptomatic thoracic aortic aneurysm.
The critical safety warnings are acute rupture leading to exsanguination and spinal cord ischemia. Radiologists must immediately recommend cardiothoracic surgery consultation. Advise starting anti-impulse therapy with intravenous beta blockers to target a heart rate under 60 beats per minute and systolic blood pressure between 100 and 120 millimeters, and recommend immediate computed tomography angiography of the entire aorta. Refer to cardiothoracic surgery and interventional radiology.